everybody has this. What's that? One. Great. So we'll just go over some of the video guidelines. We'll talk about intermittent fasting. That's something that I used to do in the past. Intermittently, I still do it. Um, what behavior we can change. But first, we'll talk about the type of diet and then how we can change our behavior to make this effective. Because I don't see us giving any type of recommendation on diet if people can't follow it. And that's why we have to change patients' behaviors to enable a diet. But if they don't want to do the diet, that's a whole different topic. So just to go over some of the guidelines of what KDIGO recommended, these are just screenshots from the guidelines itself. They essentially advise people higher consumption of plant-based foods compared to animal-based. No surprise. Lower consumption of ultra-processed foods. It's recommended to use renal dietitians, accredited nutrition providers to educate patients with CKD about dietary adaptations. I guess I'll go over different nuances of what to eat and what not to eat. The KDIGO guidelines regarding protein intake, they essentially recommend maintaining a protein intake of 0.8 grams per kilogram of body weight. They recommend to avoid high protein intake, more than 1.3 grams per kg. In adults with CKD. We'll go over the mechanism behind that later on during the presentation. It's essentially hyperinfiltration. I was surprised to actually read this in the middle point right here. People with CKD who are willing and able or at risk of kidney failure should consider, under close supervision, a very low protein diet, 0.3 to 0.4 grams per kg, supplemented with essential amino acids or keto acid analogs. I didn't really know what this keto acid analogs were until I looked it up like a few nights ago. It's essentially basic amino acid chains that doesn't contain the nitrogen component. It's less acidic. They don't recommend to prescribe a very low or low protein diet in metabolically unstable people with CKD. Go a little bit more, less than 2 grams of sodium. That's much into that. So this is another interesting, I thought, too, in patients with CKD. We get a lot of patients in our CKD clinic that just have mild hyperkalemia. They're just on the borderline, like 5.7. And they come to the clinic and what I tell them, to cut back on the tomato sauce, cut back on just the potassium diet, potatoes. What I looked into more was it's actually more foods rich in bioavailable potassium. So what does that mean? This kind of explains a little bit better. Essentially, processed foods, animal-based foods, have more bioabsorption of potassium compared to plant-based foods. The bioavailability from plant-based foods are 50 to 60% compared to animal, which is 70 to 90. And processed foods have more of the absorption, from 90%. And obviously, kind of hard to tell them to stop eating fruits and vegetables causing their hyperkalemia, because overall these foods have a lot more benefit compared to more processed foods than animal-based foods relative to kidney function. I don't think I have anything else to talk about more. Oh, that's why. So the guidelines also posted like a small little article attached to it. This is more from like a diet guideline management. What do you do if your potassium is high? It essentially recommends to have fresh fruits, vegetables, and whole grains. So actually telling my patients to stay away from all these things, from fresh foods. But actually to stay away from processed foods, juices, and soups. I guess those are more concentrated and more potassium than fresh fruit and vegetables. Also eat a balanced diet. Enjoy protein food in moderation is recommended. Limit additives to their food, such as salt substitutions or preservatives. I wasn't too sure of this, but I think the dash salt, I think that's high in potassium. And I guess an advice would be for them to read their nutrition labels. And it kind of will tell you if there's potassium. And it does tell you on the nutrition label itself. Some other foods that contain a lot of processed potassium, processed meats, electrolytes, like Gatorade, salt substitutions.
And I'm gonna interrupt and just
Sure.
say that I did look at what is the potassium concentration in Gatorade. 5 milliequivalents per liter.
5.
Gator Light has a lot more.
Powerade has 20.
Powerade has a lot.
Powerade has a lot. Gatorade actually is very little.
Yeah.
But so that's not correct. I don't know that
I don't know why they posted it then.
it's all sodium. Actually, so the sodium concentration in Gatorade is only 19 milliequivalents per liter.
Yeah.
Okay. So I wish we used, when Bob Cade was alive, he gave talks on how he developed Gatorade. I could reprise that, but I apologize for interrupting.
Yeah, no problem. Feel free to
Just to
interrupt.
supplement that, I think after Pepsi bought it, the sodium content used to be 3 grams per liter before. After Pepsi bought it, because people don't like the taste, they cut it down to 1 gram per liter. So
I
the
thought it
content
was
is not
always
same
about
as
equal
it
that
used
of
to be.
sweat.
3 grams is equal to sweat, I think, right?
No, it's actually less than sweat because if you actually, that's. The purpose of the sodium was solely to enable sodium glucose co-transporter to generate an ionic gradient for water absorption. Actually, you don't need the sodium at all because you ask what happens to serum sodium in response to sweating will actually become hypernatremic with large amounts of sweating. So we don't need to replace what's being lost in the sweating. The goal is solely to facilitate intestinal water absorption.
But you do get volume depleted if you sweat excessively, right?
But that's why the importance of Gatorade is to maintain, you get water depleted more than you get sodium depleted.
But people drink water, but the salt, how do you get? That's the question.
I'm telling you the data that Bob Cade developed. When he, we'll not go through it all now, we can talk afterwards.
Sure. Another method that you can do to decrease your potassium, and this is like about the same little article. It talked about how you can lower your potassium. Increase your fiber intake. The whole concept was to improve your to have regular bowel movements, and eat whole grains and fruits. Cooking methods. I was actually surprised about this. You can actually reduce the amount of potassium in foods by boiling it twice. Draining it, I mean, that makes sense. I didn't know that you could actually soak it too. Apparently you soak it for up to 8 hours. These are usually foods that have a lot of, that have a root to potatoes. Not the anything else there to do with that. These are other foods that have high potassium. Chocolate, it's a high one. Potatoes, tomato sauce, dried fruits, chocolate milk, potato chips. This is essentially all that I eat, except everything on the right side. This is just the last component of the KDIGO guidelines. They're just recommending a plant-based diet based off of the Mediterranean style to improve lipid modifying therapy to improve cardiovascular disease. So I think the first thing that I wanted to talk about was intermittent fasting. I don't know if some of you guys do this on your own or some of you do it here and there. I used to do it like a good amount of times here and there. Essentially the most popular intermittent fasting strategy is typically like 16 and 8. 16 hours of fasting, and then you eat for an 8-hour period. Why is this beneficial? There's less food going in your mouth, essentially. And at the same time, you're in the fasting state compared to the fed state. And if you look at this little diagram here on the left, you can see the nutrients are on the left and the fasting is typically on the right side, but it goes through a pathway that avoids the mTOR. I'll go over a little bit more in the few slides. But when you do intermittent fasting, the whole goal is to minimize the anabolic process. synthesis, growth, and reproductions, favoring the maintenance and repair systems to enhance stress resistance, recycling damaged molecules, stimulating the mitochondrial biogenesis, and promoting cell growth, cell survival, not growth. Look at the bottom right here, it's just a little component of how intermittent fasting connects to your metabolism. You get cell survival, mitochondrial biogenesis, glucose and lipid metabolism. So, I mean, this is part of the New England Journal article. This was published in 2019. They kind of said, oh, this is beneficial for this and that and this. And then like these are the potential mechanisms. So on the left is intermittent fasting on this side, but the periods of intermittent fasting. On the right is the fasting. You've decreased insulin with fasting, and you have increased when you actually have food in your system. And it also takes the mTOR pathway too. You have decreased autophagy from your mitochondria and just cell death, so you get accumulation of cells, cell growth. As opposed to fasting, you have more autophagy, increased DNA repair. The consequences long-term from intermittent fasting is more on the right. Reduced abdominal fat, reduced inflammation, reduced blood pressure, increased insulin sensitivity. Essentially, they found it was better. But then they did more trials with it. They compared that to just calorie restriction. Restrict your calories versus just fast. Both groups had the same amount of calories. They essentially didn't find that much of a difference between the two different groups. And this is like 3 years later when they compared different groups. They compared their waist circumference, body percentage fat. Body weight was another thing, weight circumference. They also compared their blood pressures, triglycerides, total cholesterol, LDL. They compared to their insulin resistance. And essentially, they concluded that it's essentially kind of equivalent in terms of how much benefit you get. And the whole process how intermittent fasting works is essentially through caloric restriction. So they kind of stated that among patients with obesity, a regimen of time-restricted eating was now more beneficial with regard to reduction in body weight, body fat, or metabolic risk factors than daily calorie restriction. It's more about what you eat rather than when you eat it. But I think intermittent fasting could be a good way to do caloric restriction. It kind of trains your body in a way to do caloric restriction instead of you just thinking about, I don't have to eat less. Well, everybody has their own ways. But some of the studies did point that there's more insulin reduction in intermittent fasting, but it's overall there's small studies about it. So my other question was, can intermittent fasting help people with CKD? Would you recommend that to patients with CKD? Because it has these different processes where you can actually have increased insulin sensitivity, you have reduced inflammation. I was just thinking maybe can this help you with CKD? So what they did among patients with CKD, this was like a proposed mechanism of how it would work. Just the mitochondrial homeostasis, how it regulates that. You have ketone bodies, you have increased autophagy, and the concept was maybe this would be renal protection. There was just small studies here and there that kind of showed that it did have some benefit, but they really small studies. Yeah, they help with diabetic nephropathy, but overall there's not enough data. It's just small pilot studies, animal models, and comparing it long term, the data is lacking. So you really can't recommend anything about intermittent fasting and kidney function. So we can move on and we can just talk about diet. If you look at kidney disease, it affects about 15% of the US population. I'm sure that's growing. That number is probably a little lower than what it should be. A lot of it has to do with Western diet, the dense caloric Western diet. It's high in animal protein. It's low in fruit and vegetable content. We'll go over different mechanisms of how that kind of affects the kidney. It takes effect in CKD. And we'll compare that to how fruits and vegetables are a little bit more better for you. So before we go there, we just have to, I thought this was actually interesting too. Just understand that just how the kidney functions itself. Individuals usually have like 1.8 million nephrons. Not all of it's working together. A lot of it there has to be some redundancy to it. So what happens in normal kidney function, we essentially protect the kidney from hemodynamic injury by vasoconstricting the afferent arteriole and vasodilating the efferent. That's so you maintain a constant glomerular pressure. What happens in a compromised state, this is usually people in obesity that increased metabolic demands, the kidney has to work a little harder. So what happens is they usually are more prone to dietary factors like high animal protein. And essentially how that works is hyperfiltration. And it interferes the kidney's ability to auto-regulate. So this is the normal kidney, the normal afferent arteriole and efferent arteriole. What happens when you have a high diet with animal protein? It increases the blood flow to the kidney, and you get impaired autoregulation. And at the same time, with that comes consequential long-term damage to the kidney with hyperfiltration injury. You get tumor beta factor growth. I'll talk about that a little later. So how does animal protein affect the kidneys? I thought this was also interesting. I'm sure some of you guys all were in the past were trying to build muscles and stuff like that. That was just my high school years. Here I was thinking maybe I should eat more protein. So and then I read this, I'm like, oh man, thank God my renal function was normal. So how does protein consumption affect your kidneys? So after a meal, both the renal blood flow and your GFR may increase up to 30%. How does that happen? Amino acids trigger multiple mediators to vasodilate the afferent arteriole, increasing blood flow to the glomerulus, and then you get increased pressure within the glomerulus, right? And this is where all the damage occurs because you're eating a lot of protein. And then you get extension of the glomerulus arteries lead to mesangial cells, stimulating production of collagen and extracellular matrix, causing this. So other things associated with this is that animal high protein diets increase your albumin levels. I mean, your albumin levels because of the high pressure within the kidney. At the same time, it can affect the podocytes surrounding the glomerulus. How that does so is essentially through high diet with meats, you produce advanced glycation end products, and they bind to the podocytes. They damage the podocytes, and they kind of cause death to podocytes, and that results in podocytes leaking the protein. This is just a little diagram showing how not just from the AGA formation, but from the pressure itself, you get stretching of the capillary walls. This leads to tension, and you have albuminuria. Just from increased from the capillary wall tension of the cells itself of the capillary. So this slide's this is more of gut-derived uremic toxins. Two things I think they mentioned was TMAO, trimethylene N-oxide, and P-cressyl sulfate. These are found from the gut, and they're usually associated with high protein and egg intake. How does this affect the kidneys? This usually accumulates and causes accelerated kidney damage, essentially from the gut microbiome. I didn't find any other resources with this, but I'm not too sure if this is controversial. I never read this anywhere else. I don't know if anybody else has any other opinions on this topic. So the clinical trials currently regarding for protein restriction was one the most famous one, I think, was the MDRD study. Randomized 585 adults with CKD to either high protein diet and low protein diet. The low protein diet had about 0.58 grams of protein per kg, and essentially didn't find any statistical significance in the overall findings, or essentially none. But they did show that there was a slower decline in GFR with the low protein diet. So I thought that was interesting, and then that kind of coincides with our KDIGA guidelines with the low protein diet. And they also found that very low protein reduced the risk of progression of ESRD by 35% among patients with advanced kidney disease. There was a meta-analysis findings with it, and it showed a moderate of protein restriction on GFR decline. Also found that there was, if you moderated your protein, you have a slower kidney function decline too.
That's the question.
Yeah.
So the MDRD is a prospective study.
Mhm.
And then the meta-analysis, are they using only RCTs or they're using retrospective studies in it?
That's I'm not so sure.
Because there'll be significant bias, right? People who eat animal protein tend to have different lifestyle than people who eat in a retrospective study.
Yeah.
So GFR will go lower in those patients for multiple reasons, which you can't account for unless it's a prospective study. So what I'm trying to say is a prospective study data is much more important than meta-analysis of retrospective studies.
Okay.
You know what I mean?
Yeah. So yeah, I don't recall that in the studies. Like,
I'm not sure if we can make a conclusion from a prospective study. How can we make a conclusion from retrospective study which are poor quality using meta-analysis?
yeah. I think it was mixed. There was like a bunch of different trials.
I'm just curious. I don't know I don't know which one they use.
I'm not too sure.
Okay.
Why would people with animal protein diet?
So let's say you live in suburbs, your socioeconomic status is different. Somebody who lives in downtown, their socioeconomic status is different. Your protein intake will be lower than the person who lives in downtown. How are you gonna account that in a retrospective study?
McDonald's cheeseburgers are $1.
Yeah, that's what I'm saying. They have retrospective studies. There's so many reasons to have patients who were eating hypertension diet to lose kidney function for so many reasons that's not related to protein. Is what I'm trying to say. I don't know how to remove the bias.
If you've been here, UF, where the MDRD trial, where UF was the largest enroller of all the centers in the MDRD trial. Ancient history, I understand that. And followed that over the years. I'm pretty certain that the meta-analyses did include the good meta-analyses only use prospective
Very good.
studies.
Thank you.
So the problem with the MDRD trial, I apologize for 32 seconds on this, was that there is an acute decrease in GFR by switching to a low protein diet. You lose the glomerular hyperfiltration, and then you have a slower loss of renal function. The problem was that after 3 years, which is what they had money for, the two balanced out. And there was no difference in GFR, number of patients on dialysis after 3 years of average follow-up. And they tried to get more money and said, if we carried out for 5, 6, 8 years, then we'll show a difference. In the end, I said, you spent a bunch of money already. I think the MDRD trial was over $100 million. And the NIH refused to allow the trial to continue. So after 3 years,
I see.
the short-term decrease in GFR was counterbalanced by a slower rate, and they exactly balanced out. That's what we can say.
Thank you.
If you don't mind, can I ask one more question since we are on the MDRD? Did you find the data on the people who did develop ESRD with this strategy? Because albumin is one of the strongest predictor of mortality on dialysis. So I'm not sure, at least I'm not aware of the data which sort of looks at this pre-dialysis protein restriction and its impact on post-dialysis. Did you find anything? Are you aware?
Yeah, no difference in serum albumin with dietary protein restriction. So that the levels used in this, I don't know where that statement came from. In the MDRD trial, there's no difference in the serum albumins. And one of the comments was carefully monitoring protein restriction. That's why when they did the group that did the very low protein with the keto acid supplementation, they had to have the keto acid supplementation in order to maintain adequate nitrogen stores, make albumin.
How low was very low protein?
If you go back to so they had the MDRD is complicated because they had two different protein restriction algorithms, depending on whether your eGFR, I think, was 20 to 45 or 45 to 60. In the 25 to 20 to 45 range, and don't quote me on the exact numbers, I think it was comparing 0.8 grams per kilo versus 0.4 grams per kilo with keto acid supplementation. So that,
So, these are a few more studies, about the protein type versus the protein amount. What they did kind of notice was that the protein type may be more important for kidney disease progression than the total amount of protein. There's another Chinese cohort study, what they found was that higher red meat intake was associated with increased ESRD. There was an ARIC study. What they also found was congruent with the Chinese cohort study, increased red and processed meat was associated with 20% more increased risk of CKD. But they did find that, based off the DASH diet, increased red and processed meat and high intake of fruit, low intake of red and processed meats and high intake of fruits and vegetables was associated with a lower risk of CKD. And this is just the phosphate and kidney function. Essentially just says plant-based phosphate is less absorbed. That's mainly it's from this enzyme which requires phosphate. That's how it comes from with plants. It results in lower net absorption of phosphorus compared to animal protein. And essentially, we know how phosphorus is low. It's harmful. It facilitates binding of calcium deposits in the kidneys, and that's the proposed risk with it. They look at dietary fat and kidney function. What the study showed so far with saturated fats intake and kidney function decline through a cross-sectional study showed an association with increased urine albumin excretion. What they saw with omega-3 fatty acids, what we think are helpful for us, show that there's decreased mesangial cell proliferation, enhanced endothelial function, and lower blood pressure. What does the clinical evidence to show us? There's no benefit from omega-3 fatty acids to slow GFR decline, but it did demonstrate small reductions in urine protein excretion. Salt intake, kidney function. How does this affect our kidneys? We all know how salt can affect our kidneys. This essentially shows how increased pressure causes kidney dysfunction, impaired renal autoregulation, increased oxidative stress. This essentially causes kidney scarring through TGF beta upregulation. And just recommendations to be less than 2 grams of salt a day.
Sodium.
Oh, sodium, yeah, sorry. And what I thought about this was, I think this is one of the biggest harpers of patients that I've seen in all my clinics. Having them restrict their salt in the diet that they have is, I think, educating them what has salt in it. It's essentially everything we eat nowadays. Processed meats, ham, sausage, bacon, salami. A lot of breads actually have a lot of salt in it. Sauces, just the burger, potatoes. That's what I was kind of surprised on. I mean, there's a lot of things that we eat nowadays that has salt in it, and patients might think that they don't have salt in their diet, but they actually do. And I think going over their diet and asking them what they actually eat and actually tell you more, and that's the best thing that you can do to reduce their salt. Well, they actually think they're not eating as much salt. More into fruits and vegetables. How do fruits and vegetables help your kidney function? Is essentially lowers your acid load, reduces acid excretion. And what they found was the ammonia excretion. It went up threefold with higher acid food, more meat essentially. It essentially balances more. It's like giving bicarb. That's essentially how that works. Diet and fiber and inflammation. What they saw was, Western diet doesn't really have much fiber intake, but if you supplement it with high fruits, vegetables, it could potentially increase or decrease inflammatory markers. other things with this slide. I think this was kind of reporting part of the information that I found. I think this was a more interesting article. This is more focused on plant-based diet. This was essentially a systemic review. It was a meta-analysis. And this was more current. I think there was a good journal called the Renal Journal, Nutrition Renal Journal. That has a lot of different topics and what diets can help us. I wanted to put more things from there, but I think this is, I just wanted to focus on the plant-based diet. They essentially concluded and they said that plant-based diet was linked to a 26% lower incidence of CKD. And they did this with hundreds of thousands of participants over 11 years. They also showed that higher intake of plant-based foods showed slower progression of CKD and the incidence, and they slowed the progression of CKD. Essentially does acid-base balance. It has beneficial protein composition. What I thought this was interesting was, I think, specific amino acids such as glutamic acid, proline, and cysteine. I think it's threonine, histidine were more with plant-based diets. And this actually was associated with better blood pressure control. And these are usually more founded plants. We already talked about reduced uremic toxins, increased fibrate and glycemic control with plant-based diets. They're associated with better metabolic risk factors. More information about this is just summarizing that article. 11-year follow-up. I think after they excluded people, it was 93,000, 26% risk reduction of incidence of CKD among those followed a plant-based diet. Other things, on the odds ratio they found was 0.86. Suggested plant-based diet offered an independent protective benefit beyond managing common risk factors. So I think this was actually a key part of like just diet itself. I think this is something that we kind of overlook among our patients, and that's habit formation. I think we all have a component of this. I mean, we don't really think about what we eat. We just eat, how much over time we really, oh, let me see what I can eat healthy. I don't think that really happens. We just, every day we make choices about what we eat, but it's usually at the end of the day, just based off, sometimes based off of impulse. You finish rounding, you're kind of stressed, and you eat something and you're starving, and you finish all your notes. And you just eat whatever you get, you don't really have that many options. So this is something that I read in a book a little while ago. This is usually habit forms. Usually there's a contextual clue, your environment, you're at Shan's, your only options are pretty much what you have in the cafeteria, unless you pack your own food. That's a whole different thing that you can actually do. And then you do it over again. You go to the cafeteria, you get the food and you eat. And then it just becomes a repetitive pattern. The more you do it, the more used to you'll become. So what we could do is we could actually change that. We can do that by changing the contextual clue, changing our environment. That's essentially the time, place, event. Looks like if you move to a different place, you'll have a whole new different pattern of doing things. That'll change your habit. And you can tie that in with diet too. So the first things first is to recognize your triggers. What identifies your eating pattern? Do you feel hungry in a certain way at a certain time? The trigger, then you have to identify the cue. Other triggers associated with it. And then you have to disrupt the action, and then you have to form a new habit. I think triggers sometimes could be like you're on your way back to work. You see like maybe McDonald's, or you see Chick-fil-A, okay, just stop by. It's right here. It's convenient. It's the same concept as like Amazon. You just do one click and you have it. It'll be there next door. So these are just habits of. These are just different triggers that you have to actually identify and recognize. And those are different ways you can form the new habit. So what you do is, oh man, this messed up. Yeah, essentially what you do is you need an if-then statement. This is like a backup. This is like, okay, what am I going to eat today? Like if you actually have it pre-planned on what you're going to eat, say you actually pack food and everything, you have everything ready, and then you walk by the cafeteria and you think, oh, maybe I should get this yummy, delicious thing over there. It's like you just tell yourself, oh no, I don't need to get it. I already packed food. So that's one way to do it. Say you're driving home and you see a Chick-fil-A, McDonald's or something, and then you tell yourself, oh, I'm almost done, let me just eat at home. So you have to do a lot of reading and preparation on how to form a habit. And then essentially once you find certain ways to avoid your bad habits, you have to fill it in with good habits. And once you get rid of those bad habits, you start doing the good habits over and over again repetitively. And that's how you form a good habit. I don't have much more. So meal planning was one thing that the patients could do. Strategic shopping, buy what you eat, essentially, what you like to eat too. Visible and healthy options. What you can do is you can go to your pantry and essentially throw away everything back. It's harder to do, but it's overall beneficial for you. So that's my renal grand rounds. Any questions?
So going back to where you said, you mentioned about intermittent fasting and calorie deficit.
Yeah.
How they're essentially, at least for the first part, that there's pretty much the same benefit. Was there any evidence on which one was easier for patients? Did they stick more to the intermittent fasting?
Yeah,
Was that like
so-
mentally easier
Yeah, exactly.
to just like
So
stick to it?
I tried to look that up too. What's more easier to follow, intermittent fasting versus calorie
Right.
fasting? From what I looked up, it seemed like intermittent fasting was actually easier to follow than reducing your calorie intake. Because when you have to reduce your calorie intake, you actually have to like count
Right.
what you're eating. That's a little bit more painful for patients, as opposed to you tell your mind like, okay, I'm only eating from 12 o'clock and 8 o'clock.
Yeah.
And then I mean, in between that time, you can eat like, a popcorn. You can eat a popcorn and you
Yeah.
pretty much broke your calorie restriction. But I thought this was actually interesting because some of the studies did show some benefit, but I don't think it's like large enough. But I think it's a great way for patients to lose weight.
I think I overall really like to talk. I actually, when I was looking into things to talk about, one of them was nutrition, because I think patients ask us
Yeah.
a lot about it. And we have so little time to actually counsel them on like all these things that we need to talk about. So I try to look up like little snippets of information that I can tell them. I saw an article once of like evaluating how patients improved by doing one single change. I think it was like diabetic patients, and instead of using whole milk, they went down to like 3% milk, and just like how one little change in their whole diet can make a difference. So I try to like tell them, what's one thing that you do every day? Do you drink soda? Let's cut that one thing down. And so I think that's from the amount of time that we have to do a small intervention, finding which one of those interventions is like the highest, will bring us the highest yield is good. So I think this is a good place to start to kind of like give me more tools to be able to do that. So thank you.
And I like what you said about starting by just having them take inventory of what food they eat.
Yeah.
Right, because just spending time, a few days,
Exactly.
or after life and work and everything, which is what am I eating? And they may identify like one thing that is really contributing a lot of bad stuff that they don't even feel that strongly about. So then you can make a big difference. Instead of just, ramming down their throat the 10 things they need to do, which is unlikely they're going to do any of them.
I mean, their patients are smart. They know what's right and wrong. Right? It's them making the decision. Yeah, that's the hardest.
Well, but it's also awareness. I think, like when my stone patient came and said, "We eat salt." Like it says here in your 24-hour, you already had 7 grams this day. What did you eat yesterday? Well, I drive through McDonald's, got 2 breakfast burritos. I had a big one with large fries at lunch. I had a block of Velveeta cheese in the afternoon. I'm like, oh my God. I'm not aware.
You don't need salt on it.
I think, so I had a question. Did you find, did you find a good study on these high protein diet intervention or counseling intervention and supplement and its outcome, both one on albumin on dialysis and 2 on long-term outcomes like mortality?
High protein diets?
So, I mean, all your talk is about CKD to ESRD transition. I think you went there for the ESRD component. And then on ESRD, the most common problem ends up being, especially when you start looking at the NPMA and everything, is actually malnutrition or under intake of protein. So commonly we have people with hypoalbuminemia, actually very common, and we have low NPMA or NPCR, which is really want to call it. And that's measure of how much protein you take per kg of your body weight. And so it's normalized for your body. And what we find is on ESRD is conventionally, people have difficulty reaching their quote unquote recommended measure. And you can call it 0.8, 1 or 1.2, and they have hypoalbuminemia. So the ESRD and the CMS funds. So that's why every dialysis unit has a dietitian, because these are CMS reimbursable activities, so for which the dialysis unit gets money. That's the reason why you're dietitian in dialysis unit, not because your patient needs it, but because it's reimbursable event, right? So
People also think it's too.
but that so the reason why they are there is because these people get that reimbursed so that the dialysis unit can hire it, right? So and it's a part of your now burden. So the common problem there is low protein intake. So there is this whole effort towards counseling and increasing protein intake and playing at this whole game of increase protein, but not phosphorus and not salt, but sometimes increase potassium, sometimes decrease potassium in the whole game. And so did you find a good study? Did you try to, I'm sorry. Sorry, but by the time I explained that, I realized that you are not focusing on that.
Other thing that I came across that was interesting, but I didn't put up here was actually coffee can reduce your incidence of chronic kidney disease. I think that was interesting.
That's just, yeah, but they never those quality studies, especially, your large study in the, it's all
More of the sign of
recall,
Yeah,
right?
it's not that reliable.
Sorry, go
is
ahead.
it surrogate marker for just the subset of patients that are not doing well? It's more than nutrition. Would you agree with that?
That's the main thing that we all struggle with.
Yeah.
That it's everybody, and I think yesterday we talked on something
Yeah.
else. Albumin is a marker of a bad
Overall
outcome.
health. I would
Yeah,
say.
overall outcome.
If you look at the albumin of somebody, you decide how long they're going to be alive. But having said that, no, for the yes. So the thing is that
This is true, by the
I
way.
wish Dr. Ilkun was here. Dr. Ilkun tried this giving albumin to the dialysis unit at Shan Kidney Center. They increase the albumin level, as you say. That's the trick. You give somebody albumin, the serum albumin goes on. And they showed that their hospitalization rate was lower. This is an association study. This is just keeping that in mind. I wish she was here to tell us a little bit more about it.
Yeah, so I'm trying.
Dr. Ilkin is here. Dr. Kazori, I'm listening to the whole talk. And good job, Dr. Michael. I really enjoyed the presentation and watching it. And yes, first of all, very interesting comparison of intermittent fasting to just decreasing calories throughout the day. And secondly, yes, for increasing protein intake for dialysis patients is very important. Dialysis machines does actively remove protein, right, from the blood and albumin. And so does peritoneal dialysis, even more so. So 10 grams approximately if for hemodialysis, 15 grams per session for PD. So supplementing that actively to the patient is a big deal. And yes, we did show that there is a correlation, right? It's an association. There's no causation that we can prove with a quality improvement study design, but we can prove correlation, or we can show correlation between decreased hospitalizations over 12 months as compared for people who have received protein supplementation on hemodialysis at the end of each hemodialysis session versus those who didn't, if they started with lower levels of albumin. And those who had albumin less than 3.5 were the ones who benefited the most. And we shall never forget, right, those are active phase, this is active phase reactant. It could be, a presentation of occult malignancy, which we haven't discovered yet, or known active malignancy, or infection somewhere in the toes or anywhere else. right? Which is another thing that I have implemented is, asking the patient, do you have skin breakdown anywhere on your body? Right, when we round on hemodialysis or PD. It's important to know what low albumin is telling us. All right, thank you so much. I'll let everyone else.
Yeah,
I didn't know you were there. Very scary.
I think it's important to look at the supplementation data with mortality outcomes. And I think there is a little bit of a break over there, that the data is coming out are on soft data. And I think this is good data. And this is a great way of sort of doing it, right? So when you do QI, you can correlate your actions to some meaningful improvement. And so that actually tells you are doing something. But I think there is an overall, on a bigger picture, there is a concern that whether supplementing is, again, those who improve and those who supplement and then they improve, whether it's a marker of their baseline health versus what. So I think there appears to be a two class of people, and that's what I want to say.
Also, if you don't mind, I just want to make a comment on your potassium slide.
Yeah.
I thought that very telling, and this is a source of common mistake. So for the potassium, we tend to tell the patients, actually, I have a lot of these patients with heart failure, so by those diuretics, low potassium, and they're on potassium supplementation. And I used to tell them, oh, instead of 20 mg of potassium that you're taking the pill, just take 2 small bananas or 1 big banana, it will do the job. It wouldn't do the job actually, because the potassium in the fruits is an organic salt. So the absorption is much less than the tablet that they get. So you should be careful when you are doing they tell you that a potassium in a big banana is around 20 mg.
Okay.
But it does not equal the 20 mg potassium pill that.
Because it's not absorbed as.
Yes.
Amir, I'd be interested in the data behind that, because I've written a number of papers and the literature really has said bioavailability of potassium, regardless of the source, if it's in a salt, it's 100% in the GI tract. And so dietary, from my understanding, dietary potassium, whether it's from a banana or from PCL, is 100%.
Actually, if you look at up to date says that it is around 50-60%, the same thing that he's saying. It might be wrong, it might be old data, but the assumption is that the bioavailability is not 100%. But that's might be again old data.
Oh, Dr. Kazuri, I think this is valid. And same thing with phosphate, right? Phosphate that is added to foods as preservative is much more bioavailable than the one that comes from foods, with all protein and fiber in it, and it's easier to excrete through GI tract when it's compounded with something that is easy to exit, just like with bananas. It has fiber in it and potassium. Some of it, I'm sure, will just get trapped and other than 100% absorbed as compared to salt substitute, right? Potassium chloride.
No. Someone, I have no idea. Someone. Just leave.